Hello, I'm Daniel Margolis, and it's my pleasure to present to you again, this time on the standardized MRI and molecular imaging reporting for focal therapy follow-up, creating image-based short and intermediate outcomes. Again, I'm a consultant for Promaxo and Gerbet. I'm going to start by talking about post-treatment imaging, and then a little bit about focal therapy effects, and some news, including a proposed standardized reporting template for MRI, and finally, molecular imaging for focal therapy follow-up. So this is a little different than last year. Last year, I also talked about planning, and this year I'm also going to include some molecular imaging. So the first thing is to reiterate post-treatment imaging. As you know, PI-RADS is designed for assessing primary significant cancer, meaning untreated cancer. The prostate imaging for recurrence reporting system focuses primarily on dynamic contrast and high B-value DWI rather than T2-weighted imaging in ADC, as is important in PI-RADS. And there are 5 different categories of suspicion, just like in PI-RADS, but it focuses primarily on whether or not the abnormality is on the site of the original tumor. So either the same site in radiation therapy or the same site for surgery, as we see here. And here's a rubric for post-radiation reporting. And you see that if there is an abnormality that is contralateral to the original tumor, this would be category 4. But if there is concordant abnormality on both DWI and DCE, this is overall category 5. So DCE is the dominant sequence. And if you get both DCE and DWI abnormality, that's category 5. So what are some focal therapy effects? Again, just like we see after surgery, where there's low signal on DWI, T2, ADC, and DCE in the normal phase, when there's recurrence, we see low signal on ADC and T2, but high signal on DCE and DWI. The same thing after radiation therapy. Note that the gland has this diffusely, heterogeneously low signal on T2 and ADC, which is why DCE and DWI are so important. Here's an example after cryotherapy. In the anterior gland, we see that it too has low signal on T2-weighted imaging, ADC, as well as DWI and DCE. And this marginal recurrence, while low signal on T2-weighted imaging and ADC, has high signal on DWI and DCE. We also know that the gland changes in both shape and size. My colleagues in the Department of Urology published this a few years ago. So this can change both the orientation of the prostate and the treated zone. We should also consider that there are early changes in the first few weeks where we see coagulative necrosis. This means high signal on T2-weighted imaging with a hypointense enhancing rim and internally restricted diffusion, similar to what we would see in an abscess. Again, absent internal enhancement early on. Now, I'd like to reiterate the system that we have for liver. So again, for the liver, we only look at enhancement. When there's no enhancement of the treated zone, we consider that non-viable. When there's nodular enhancement, we consider that viable. And when there's a sort of nodular rim, that's equivocal. And here's an example where you see this thin rim of enhancement with no internal enhancement, which is considered non-viable, compared with a nodular enhancement at a treatment zone, which is considered viable disease in a treated liver. So this brings up the issue, when should we image and what do we want to describe? So early effects that I mentioned generally occur within the first 2 weeks, definitely within the first 3 months. And then the late effects generally occur from 3 to 6 months or later. Also, we need to consider that outside of the treatment zone, we would still use PI-RADS for suspicion categorization. For the treatment zone, we want to consider the characteristics that we use in PI-RADS, whether it's nodular or diffuse or linear in terms of size, and we also want to consider benign changes. And that brings us to what's new for this year. Importantly, the proposed standardization reporting for MRI. So there are some other innovations. There was a meta-analysis post-HIFU looking at 703 patients. 19 studies satisfied at least 4 of 7 Quadas components and had good sensitivity and very good specificity. However, there was a single center site that found excellent specificity, but relatively poor sensitivity. So there's a lot of variation across centers. And that raises the importance of the prostate imaging after focal ablation, or PIFAB standard, proposed by the University College London group. This has 3 categories analogous to the post-treatment liver imaging. And just like post-treatment liver and PIRR, it relies primarily on DCE. Here's the rubric that we use. You'll see that the first component that we consider is dynamic contrast, and then the high B-value DWI. We expect that diffusion, the ADC map, and T2-weighted imaging will be abnormal in all cases. So where there is an abnormality on dynamic contrast, but not on the high B-value DWI, then we consider features that may suggest benignity, such as linear rim of enhancement or not at the site of the original tumor. And then whether it's nodular and within the ablated zone. And this indicates the management of this new system. And I'm going to talk a little bit about molecular imaging for focal therapy follow-up. So there are 3 standards for evaluating PSMA PET. It's the N and the M that are emphasized, but these rely primarily on evaluation of metastases. So while they are TNM based, it's the N and the M that are emphasized: PROMIS, ePSMA, and PSMA RADS. Also, there was a case report from UCLA where PSMA PET was used to guide treatment, and there was concordant absent PSMA activity and absent cancer on follow-up biopsy in this case. There's also a pilot study from Stanford looking at PSMA and the RM2 gastrin-releasing peptide agent after HIFU. And this found that for PSMA 11, there was 100% sensitivity for recurrent disease in this case. There are a few other studies of note, one looking at fluciclovine, but this was found to be not useful for informing who should undergo biopsy at 2 years after cryoablation. One looking at PSMA on a quadrant basis. This also showed excellent specificity with relatively lower sensitivity, and all grade group 3 and above was detected, and only some cases of small volume grade group 2 was missed. There's also one case report of choline PET. So the take-home points: PIFAB has been proposed for post-ablation assessment. However, its performance remains to be determined. PSMA may be a useful adjunct, or possibly even better than MRI, but the current standardized reporting for PSMA focuses on metastatic disease rather than in-organ recurrence. Here is the bibliography of the studies that I've referenced. And I'd like to thank Admatech and Dr. Stern, as well as my colleagues, for their submission and allowing me to present this. Thank you very much.